pH is up or pH is down? pH is down. What's going on with PCO2?
Normal.
It can be normal,
Should be
or
normal.
it can be
Up.
decreased. If we're talking just strictly a metabolic, it can be decreased because it's trying to compensate. What about the HCO3? It's going to be low, because HCO3 and pH will travel in the same direction. Yes, Shirley?
Using the end-tidal one that you're talking about, because I thought you said it goes the opposite direction.
It does, unless it's compensating.
Okay.
So remember back to the teeter totter. Remember that in response to the metabolic side, the respiratory side is going to try to increase, if it can, for that issue. If that's the case, it's going to be low. So it just depends on the condition of your patient and how well their body can compensate with that. If you want to know the most classic thing for metabolic acidosis, it's right here. Cardiac arrest or severe trauma. So nasty, decompensated shock is here. Guaranteed. Cardiogenic shock, guaranteed to be here. Severe hypovolemic shock, guaranteed to be here. So we're talking about severe blood loss. We're talking about cardiac arrest. Other causes are up there.
When your blood is sitting still, it creates lactic acid.
Yeah. And two, that's gone strictly from aerobic to anaerobic type metabolism.
We're going to talk more about aerobic
No.
now. No, we're not.
No. I have nightmares about the crust. Okay? Leave me alone.
So once again, the SAODs on this one,
Yeah, so why is that, Charlie?
I have no.
Because
Yeah, yeah.
he was saying.
I don't.
So think about it. What did I just say about the previous one? Respiratory alkalosis. Initially they start there, but over a period of time left untreated, where does it shift to? It's a metabolic problem, it's going to shift to this side right here. This is why you were stepping in to do something about it. And so as we move forward, we start talking about treatments and everything else like that. Again, it relates back to what we're talking about today. Can I go?
What kind of ECG changes?
That's the model I can do.
What kind of ECG changes?
So with hyperkalemia, we're talking about a widening of the QRS. We're talking about what they call a sine wave. And so more to follow, much more to follow on that.
Well, so like, I know you said much more, but keep going. I have something I want to say a little bit later.
Okay. Can we go? Yeah.
So if you're vomiting, you're getting rid of all those acids. So why would it be, wouldn't it be alkalosis? Because you're
So vomiting from, say, that you went out on a binge last night and you vomited today is you know, one day and you're done. You're back to healthy again. But the vomiting we're talking about here is ongoing, on and on and on and on and on and on. So you're displacing all your electrolytes, you're displacing all your other stuff along the way by that vomiting, and usually with diarrhea as well. Huh? Uh-huh.
But it seems like you're getting rid of all that stuff.
Yeah, but it doesn't quite work that way. Lactic acid does not come out through our vomit per se. Lactic acid is through the bloodstream.
It may feel like it, but it doesn't. Gary, would this be something?
Yeah.
Yeah.
Yep.
That's a good one.
All right, can I go?
So in the book it says metabolic alkalosis.
the most common cause of that is vomiting, basically.
Hang on. We need to get to that first, and then I'll come back to that, promise. So our treatment is gonna be what? For metabolic acidosis, what is our treatment going to be?
Increase fluids and give them, it's more respiratory
Very good. Excellent. Do you all hear that?
No.
We're gonna do something in terms of IV fluids. We're gonna do something in terms of maintaining vital signs. We're gonna do something in terms of taking care of the respiratory side. Because the respiratory side compensates for the metabolic side. Okay? The kicker is, on the pre-hospital side, there's not a whole lot that we're going to do to have a great effect about it. Unless you happen to have a patient that's in cardiac arrest, you can do something about that, right? But in its purest form, there's not a whole lot we're going to be able to do on the metabolic acidotic side.
So what are we gonna be looking for on the respiratory side with metabolic acidosis?
Now, let me see what else I got for you. What are we going to be looking for? We're going to be looking for the disease process. We're going to be looking for the shock state. We're going to be looking for the vital signs. We're going to be looking for the presentation.
So I was on a patient in diabetic ketoacidosis.
Yep.
Acidosis.
Yeah.
And I have never seen a case this bad, ever. And this lady was, like, she had the lip, I mean, she was, like, I honestly, if I didn't walk into Valley, because we were picking her up from Valley, if I didn't walk in there and the nurse didn't tell me what was going on, my first thing that I would have thought it was like a CHF or something, I mean, because she was presenting, and she was very agitated, and, I mean, just like, she was at the, like I said, I've never seen it.
So why do, to your point, why do DKA patients present with that Kussmaul breathing? What's going on there? Absolutely.
Yeah.
That is the best compensation I can possibly think of in life. That's it. Huh?
Smells like vodka.
Yeah.
Ew, what are you drinking?
Good vodka.
This one here,
Yeah, nice and loud.
your pH would be right about normal range, the top one on the board there.
So metabolic acidosis, your pH is going to be up or down?
Down.
Down. Your PCO2 is going to be normal or down if it's compensated. And your HCO3 is going to be what?
Down.
Down. Okay? Yes? No, Tim?
Everything's kind of a yes and no.
So the idea, why would increasing urine output be part of the answer to this?
Flush out more acid and kidneys.
Yep, but what's going on in terms of hydrogen ions? Too much or too little? So if we start getting a bunch of fluid, what are we going to do? We're going to cause the kidneys to start excreting hydrogen ions. Make sense? All right, fourth one. Metabolic alkalosis. Metabolic alkalosis. Tell me what's going on. pH is up or down? pH is up. HCO3 up. PCO2 normal or low. Actually, normal or high. It would be normal or high. It was compensated.
Normal or high?
Yeah, it was compensated. So the causes that you see up there.
pH would be up. HCO3 would be up. PCO2 would be
Yep. So you want to know the reason why we have stopped giving a bunch of Lasix to CHFers?
It's a diuretic? Because it goes through the lymphatic system.
Right, there is that as well. But right here, the idea that we can create an alcoholic state based on what's going on. Okay. So would it be preferable? Do you suppose to have an alkalotic state or acidotic state?
Alkaline.
Yeah, typically alkalotic. But the idea, like we talked about a long time ago, hours ago, the idea that if it goes too high out of control, that will kill you as well, on the high side of that. Sure.
So if you have a patient that's taking diuretics,
Yep.
and they're not really maintaining enough hydration, will it still force them them to purge that off, so like maybe they're losing those components, but it's not balanced out.
Yeah, great question.
So
That's true, yes.
Well, don't they have to take potassium if they're gonna be?
Typically, yes. Typically, because
Because that will throw everything off too.
Because what we talked about yesterday, potassium will be the regulator in terms of the entire thing, yes. All right, so the question was, in terms of why does vomiting and diarrhea show up on both sides of it?
John,
It's still a metabolic issue, any way that you look at it. The idea that it starts here, ends up on the metabolic acidotic side over a period of time, if you can't correct that, is what it's about. Just like we've been talking about, that they can slide to different states depending on how bad the disease process is.
We don't see this very often, do we?
No. Of the four of them, this is probably the one you see the least, at least in the pre-hospital side. In hospital, they will see this. So signs and symptoms would include our patient that is hyperventilating, muscle cramping, weakness, and treatment is more towards the disease process itself. No cure for this. This is not you and I doing our magic on this state, because it doesn't work that way. It's bigger problems in terms of what's going on.
So this patient's not doing very well at all.
That patient typically is not doing well for very long anyway.
So is this a process with death, like if it's a hospice patient, because things are shutting down, would this be?
So hospice patient would be more towards metabolic acidosis. End stage would be metabolic acidosis.
Okay.
Okay? All right, so there's one other thing that we've kind of talked about, but not so much, okay? Is it possible to have both a metabolic and respiratory acidosis? Give me a description of that. Yeah, but not even about blood gas. Just tell me about a patient that presents that way. Yep.
If you're in cardiac arrest,
What was that?
if you're in cardiac arrest,
Yep.
you have metabolic acidosis because lactic acid and all that stuff's not
Yep.
circulating, and
Yep.
you have respiratory acidosis because you're not breathing stuff off.
What about like, yeah, what about like?
Thank you, John.
There's nothing going on, folks. There's nothing going on. So whether or not this was a primary respiratory or primary metabolic doesn't really matter. The idea that you're treating a cardiac arrest and there's nothing going on in terms of compensating, that's the end game.
So like a good example would be like that tricyclic overdose,
Tricyclic overdose is typically going to be a metabolic acidosis,
beginning and then.
beginning and over a period of time respiratory acidosis
Correct.
that it will shift to. So yes, and we're going to camp on tricyclic overdoses. All right, can you give me another presentation to where you have both? If you think about it, you can.
Would this be potentially like a patient who has both renal failure and COPD?
Yeah, yep. That in the nth degree that would be true, but it would have to get to the nth degree before that's true. Okay. What about your patient that just did heroin and is driving down the road, slams into a tree, and is unconscious? Respiratory metabolic. So the kicker, the initial thing is going to be the primary thing is going to be the respiratory side, right? But over a period of time, that your patient then goes into this huge shock state, would then be a metabolic as well. That's another example to where it can end up being both sides. And again, it isn't like you're going to have these perfect 20/20 glasses and looking at my patient and saying, oh, it looks like you're in a respiratory and metabolic acidosis. The idea, though, is you start to get the thought process about the disease thing that's going on and how you're going to treat them because of that. Okay?
At least you're not using acidotic, not alcohol. So, when we got the metabolic, alkalotic, alkalosis, are we just stowing and going because we can't do nothing?
I wouldn't put it that way. As we get into the different disease processes, we'll see if we can't answer some of those questions for you.
Okay.
But you're kind of there in that we're not going to do any magic on these patients because they're sick.
So just go into the hospital ASAP.
And as we start talking about the disease processes, we'll see if we can answer some of that for you.
I think, part of the deal is we can't see a lot of this stuff working with meds.
Yeah, and that's...
Alright, so we're basically basing this off a history or a mechanism of
So
injury.
imagine
or a
this.
respiratory
This
rate,
afternoon,
or-
we are talking about history. This afternoon, we're talking about patient assessment. Why?
To tie all this good stuff in.
Exactly.
Index of suspicion.
Exactly. It may not be perfect. You may end up at the hospital and say, I don't have any flipping clue in terms of what's going on from an acid-base balance. But at least now you should start to have the idea in terms of what's going on and how to end up treating them. It maybe so just a hint. That's a starting process. All right, so let's work through some scenarios. You encounter a 28-year-old female for possible intentional overdose. Vital signs are blood pressure 104/60, pulse is 120, respirations are 6. She's sitting at 96% of room air, pupils are constricted and sluggish, and her GCS is 10. Tell me you haven't seen this patient before, right? So what's going on?
Respiratory down, CO2 should be up.
Alkalosis. Yeah.
So I hear all kinds of stuff.
Metabolic acidosis and respiratory issues.
6 minutes.
We said hypoventilation creates what? What kind of? Respiratory what?
Acidosis.
Respiratory acidosis, because they're under breathing, okay? Again, you see that heroin overdose, and they're only breathing about 3, 4, 5 times a minute. The idea that they're hypoventilation means what's going on inside the lungs. Retention of CO2, okay? We said retention of CO2 is about an acidotic state. It's only whether or not it's a metabolic versus a respiratory, okay? What do you want to do in terms of taking care of this patient? Give him some Narcan and breathe for him, okay? You're going to correct the acidotic state they're in by doing those things. You may not do it long term, as we'll talk about a different day, but the idea in terms of the initial treatment is towards that.
Question.
Yes?
How can their SAPs be that high with respiration?
Because one of the things I told you intentionally we're not going to talk about is the oxygen side of things. It's very, very easy, and especially with a young person, 28-year-old female, it's very, very possible that they're oxygenating okay and yet not ventilating. Remember, there's two different things. Okay? So we kind of talked about her acid-base balance as being a respiratory acidosis. We already talked about how you want to treat her. And we talked about the idea in terms of Narcan and then following up with her. And then perhaps another dose of Narcan, depending on how long before it starts decompensating.
So am I correct to say that just putting the oxygen back on the table just for 1 second?
Yep.
So we're at 96 now,
Yep.
but that's eventually going to fall because that oxygen is just residual.
So if you were not to treat her and her she goes into an apneic state, then yes, for her
But where is she
SpO2
getting that oxygen from if she's not blowing
with
oxygen? She's really not ventilating.
so
It's residual, right? Still in the
So
plasma?
check this out. With somebody that doesn't have a disease process per se, they're still going to continue to oxygenate. That's kind of the reason why with cardiac arrest these days, we don't have to be huge about oxygenating our patients. That's the whole reason for it.
Even with 6 minutes, not one.
All right, so check it out. She now has a GCS of 8. She's got a pH of 7.10, PCO2 of 68, HCO3 of 22. Tell me the state that she's in.
Just angry because they're high.
Metabolic acidosis.
Acid pH.
And respiratory.
All right, so let's go back to what we talked about. Hang on. So we started by saying that we're going to identify first what's going on with the pH. Acidosis or alkalosis?
Acidosis.
Acidosis, okay. Go to the PCO2.
Alkalosis. No, acidosis.
Acidosis. What about the HCO3? Normal. So tell me her state. No. What's the primary thing? If it's acidosis, then it can only be respiratory or metabolic. Okay? How do we make the determination?
Because the respiratory side is.
Absolutely. Respiratory side is out of whack, while the metabolic side is normal limits. Okay? It can only be a respiratory acidosis.
Are we EMTs? Did we do nothing for her?
You're heroes today. That's what you are.
We didn't do
Okay?
anything for her.
So-
Vital sucked.
You're gonna tube
The
her.
pH is below,
That's probably where they were in the beginning.
but the HCO3 is normal, so that's... So if one or One or both is normal. There's a thin range. Did I miss that part? Okay.
All right, check it out. So, Chris Munoz, you've got this. Sorry, we stopped doing multiple choice a long time ago here. All right. So let me read it out loud and then give you a second. You're encountering a 72-year-old male with nausea and vomiting. The last 3 days, he has not been eating well. He has a history of diabetes and hypertension. His vital signs are blood pressure 160/94, respirations of 32, pulse is 126, setting at 92%, room air. Glucose is 486. That should give you a clue, right? GCS is 12. What do you think, Chris?
Right away, I'm leaning towards metabolic acidosis.
Why?
First off, you mentioned history of diabetes,
Mhm.
so that started me off on that path.
Mm-hmm.
Hypertension, so there's obviously something wrong with, the way you circulate blood and stuff like that.
Uh-huh.
Blood pressure kind of supports that. Respiratory rate is 32, so he's trying to blow off the extra acid that's in his body. Pulse is supporting that as well. SpO2 is down. That's kind of, I'll put that to the side for the time being. Glucose 486 is kind of my wrapping of the pack.
Okay. So, what do you want to do in terms of taking care of them?
First of all, fluids.
Okay. Why fluids? What are you trying to do?
Kind of what we talked about earlier. We need to get his kidneys kind of kick-started to get rid of, to kind of hopefully rebalance them out, so get rid of that sugar. Hopefully that will bring his respiratory rate down, because his respiratory rate is obviously trying to compensate by blowing off the acidotic right now.
Okay.
At this point, can't do much with the blood pressure. Pulse probably won't get touched much. So at this point, just going to do fluids, maintain SpO2. I kind of do more of a history to see if there's anything else going on. He's going to have to be based off presentation. If he look like crap, or if he look okay like he's maintaining, depending on that, he may or may not get major pain.
Okay, so probably a little bit of oxygen, fluids. What does it ultimately need? Hospital, for what reason? Insulin, right? So the idea the insulin is going to correct the shock state is out of our control. Can't do anything about that, right? So check this out. Before, you don't have a blood gas machine in front of your face, and yet you figured out that this guy happens to be in a metabolic acidosis by what's going on in his presentation. That's you. Congratulations. All right, Jason Webster, you're next. You arrived at the hospital with your patient. Oh, this is our same guy. So Chris, back to this.
Yes.
pH is acidotic, right?
Okay.
PCO2 normal or not normal?
With the normal, it's on the low end
Yep.
of normal.
Yep. And what's going on with our ACO3?
His metabolic rate is acidotic.
Check. Check. Is it compensated or uncompensated?
Uncompensated.
So you're right. This is like right at the very low end. That's probably the respiratory rate is trying to do something, just not real effectively. Yeah.
So it's uncompensated or compensated?
It'd be uncompensated, but again, this is right at the level to where the body's trying to do something. You could call it either way.
It's on the way to compensate.
Check.
Oh.
All right. Jason, you encounter a 16-year-old male from MVC. He is unconscious. GCS is 7. Large amount of bleeding noted from his right femur. Blood pressure is 80/48. Respiratory is 32. Pulse is 136. What are you thinking? Listen up, guys. Listen up.
Well, he's hypovolemic.
Check.
And so, being hypovolemic, I would say that he's probably in a respiratory acidosis state.
Okay. Perhaps.
He's 16, and so he probably doesn't have a lot of, if I don't have any history coming from him, I wouldn't assume a lot of
Okay.
disease processes going on, but
You're
that would
correct.
be.
But what is his major malfunction here? Because you started off spot on.
Okay.
Is it a respiratory problem that he's having or a metabolic problem that he's having? blood loss, I told you blood loss is typically going to be on the metabolic side. So think about ectopic pregnancy, think about huge blood loss, think about anything that's going to be major blood loss, typically it's going to be more towards the metabolic side than the respiratory side. They can have both, but in a diagnosis type of thing, it's more going to be towards the metabolic. So, Jason, acidotic state or alkalotic state?
I'll pass it out.
Without a doubt, right? So, I mean, if we were just kind of eyeballing this thing, I'd be thinking about metabolic acidosis, right? Stable or unstable by this vital signs, Jason?
He's leaning towards unstable.
Without a doubt. Based on this, because they're trying to compensate, and maybe if you no longer compensate from a respiratory standpoint, and definitely this. The heart rate. Yeah. All right. So we kind of talked about more towards metabolic acidosis, and what do you want to do in terms of treating them? You're the paramedic, dude.
I can stop bleeding.
Yeah.
Then we gotta get him some oxygen. We gotta get some fluids.
What else?
Fluids?
Fluids to what? Remember, we kind of talked about the other day, we don't want to drown this guy, right?
Yeah, to maintain a good pressure.
Perfect, okay? What does he ultimately need? He needs definitive care, right? He needs blood, he needs definitive care in terms of stopping wherever that bleeding's at, right? So the idea that we are the Band-Aid in terms of getting to where we are, but the idea that we can be a huge Band-Aid if we figure out what's going on with this guy. Make sense? Hang on just a second, let me finish out with this. There you go, Jason.
So he's acidotic with a 7.01,
Yep.
very much so.
Yep.
Not doing a good job of blowing it off.
Nope.
He's at 60. And the HCl3 confirms that he's metabolically acidotic.
There you go, man. So what is this then?
He's both
Yeah.
now at this point.
It's both a respiratory and a metabolic acidosis, okay?
Completely uncompensated, so.
So the idea of, if you end up seeing this in hospital, the idea of this, if we haven't intubated this guy already, and we probably should have with a GCS of 7, right? If we haven't intubated this guy already, this is going to be part of our treatment. Yeah.
Wouldn't he be in respiratory alkalosis though? Because he's breathing too fast and ventilators.
Yeah, but again, get this. Just because they're breathing fast doesn't mean they're in the alkalotic state. If he's not moving a whole lot of air, and he's retaining CO2, so don't get wrapped around the thing about thinking that just because he's breathing fast, it's always going to be an alkalotic state. Okay? You okay? All right. Yes.
So based off the first slide, I understand why metabolic, but why the acidosis side, just based on the very first slide, the presentation of the patient. So blood loss alone means metabolic and acidotic?
But yeah, and so the idea by the idea that he had this trauma, the idea that he's got this huge blood loss, the idea then that he's hypotensive would make me suspicious on the acidotic side of this thing.
No tissue perfusion.
Check. Check. Chris.
So, I mean, kind of build on what your question is, maybe I'm wrong here, but your body naturally wants to be in a aerobic state.
Yep.
But when we enter into a mass trauma situation, it's essentially switching to a anaerobic state because it's trying to kickstart things.
Did you all hear that?
Okay, still being.
So say it one more time, Chris.
So to go off, this is the way I understand it, is our body naturally wants to be in an aerobic state. So the way I think about it is I would rather take my time running around the track versus having to sprint. And that's what our body naturally wants to do. So when we get put into a high mechanism trauma, your body can no longer take its time doing its thing. It's got to sprint to keep up. So it transitions from an aerobic to an anaerobic state, which then causes us to releasing extra ATP, stays in the blood, and makes you acidotic.
So, and again, to the point of while we're strictly talking about acid phase, ATP is part of this, right? Electrolytes are all part of this. The presentation is certainly a major part of this. Let's see. When? you've got a 74-year-old female who has witnessed her husband collapsing and now is short of breath. She is feeling faint herself, complaining of numbness and tingling all over her body. Vital signs, blood pressure 178 over 110, pulse of 110, respirators of 36. She's setting at 94%.
Who's short of breath, her or the husband? No, seriously, no, her.
Her.
So blood pressure's elevated, heart rate's elevated, respiration's elevated.
Okay.
So she's in a respiratory acidotic state?
Acidotic or alkalotic?
Alcohol.
This should be a clue right here. And you've seen all these patients. I will guarantee that each of you have seen these patients, right? Doesn't mean that it can't have a different state, but this is the one that comes to mind first.
These
So what do you
are
want?
anxiety people?
Yep, yep. Excited delirium initially starts here and goes out elsewhere.
So if you had that tingling of the periphery with that previous patient with the blood loss, could that be a metabolic as well?
Typically, you're not going to have that presentation with your previous one. Typically, you're not going to have that.
Could that be a lack of fluid, lack of hypovolemic?
Typically, you're not going to see that without, no. All right, so Lynn, what do you want to do?
Decrease her rate of breathing.
How you going to do that?
Well, in this situation, she's just upset.
Yep,
So we need to calm her down.
yep.
Not necessarily be medical, we just need to.
Well, maybe not medical, but again, you don't know the rest, but by this, yeah, you're right. You're right. So sitting with your patient, getting her chilled, slowing her breathing down, perhaps starting some oxygen, just to remind her to slow down, that type of thing, are all possibilities. Do you have to do anything dramatic with her right now?
No.
This is the patient you sat with, right?
Can I ask a question?
You can try.
These are the patients that, years ago, before I was ever an EMT, they gave a bag to
Yeah.
us, breathe into a bag. Why
Yeah.
would we stop that? It seems like it's a reasonable way to
It
reduce
does,
oxygen intake.
it does, and what we end up doing by doing that was we took this from an alkalotic state to an acidotic state in the opposite side.
She just didn't know where to stop, where to take the bag.
That's all it was.
Okay.
The bag itself was a bad idea, it's just that we went too far. I mentioned that as the EMS. Lynn, there you go.
So her pH is fine, her PCO2 is a little low, and her HCO is right in normal range, so she's respiratory alkalosis.
Woohoo! Let's see, Cody, you look like you're up for this. We've got a 56-year-old male, full cardiac arrest, bystander CPR was in progress prior to your arrival. He has pulses, apnea, cardiac rhythm is asystole.
Metabolic and respiratory aspect,
Good, why?
because you're shutting down all systems.
There's no play going on here at all, right? Nothing happening, although there's a retention of CO2, although we've gone from aerobic to anaerobic metabolism, right? So all bad stuff. What do you want to do? All the things you're getting ready to learn in the coming months, right? Let's go back. So he comes back into perfusing rhythm. He now, Cody has blood pressure at 88 over 50. He's got a pulse of 130. Spontaneous respirations at 6. His ABG is 7.02. PCO2 is 60. HCO3 of 12. And both. So he's still both, okay? Even though we've gone back into a perfusing rhythm, the idea that he's still persisting there. So again, next month, as we talked about ACLS and we talked about caring for these people, the idea that they're going to persist in this for a while until we can end up getting corrected along the way. So here's one last thing. Because there's a real temptation as we start talking about sodium bicarb. Sodium bicarb does what? It creates a base, right?
Buffer.
Why would we not want to give bicarb to all these patients that are in metabolic acidosis? Or even respiratory acidosis?
You can drop it more.
Drop what one?
The HCO3 and the pH level.
Okay, but don't you think it'd be great to be able to take that PCO2 and dump it with a bicarb? Don't you think that'd be a great thing?
Too far in the alkalosis?
Say again?
Because we go too far back to the
Yeah.
alkalosis?
That's exactly what it is. So back in the day, and it wasn't so long ago, we established yesterday that EMS has only been around for 40 years. And I will tell you that 35 years ago, the very first drug that we were given for somebody in cardiac arrest was bicarb. We didn't realize that we need to we need to ventilate our patients first and correct that before we end up giving some bicarb. We just made this thing worse. Little did we know that we were actually not helping our patients, but actually making it worse.
Because our body is trying to compensate, and then we add in the bicarb, we're overcompensating?
Perhaps, and that's part of where we're going. What we're going to be talking about in the coming days and the coming weeks is the fact of establishing ventilation first and trying to correct that, and they still persist in the acidotic state, then adding some bicarb at that point. That's the difference.
Doesn't that all depend on your EKG that you're getting to?
Not in terms of acid-base state, no.
Well, it's going to show you kind of like the different rhythms you are, so if you're like hyper K, then you like.
So hyper K, yeah, you're right. In terms of hyper K, it's a different thing, but in its purest form, not so much. Okay. You're there. All right, so here's where we're going. Monday morning, first thing, you know what we're going to be talking about? We are going to be talking about a test, but we're going to review this quickly, okay? We're not just going to let you with it. So with your questions, come with anything that you see over the weekend that doesn't make sense to you, and we'll go from there, all right? And, like I said from the start, this is not a one-time deal that you're done with us and you can wipe your brow and say, I got that. This is going to be ongoing and ongoing and ongoing and ongoing along the way. Coming back to it and back to it and back to it because people are hurting it. Okay? So we get the opportunity of coming back and visiting with us again. Any questions about that? Any questions at all on anything we talked about this morning? Don't let me start at the beginning again. All right? At 20 after, come on back at 10 to 1. We got a couple lectures before we go live this afternoon.